Next talk by Professor Amit Gupta, and he will be speaking about how we can think out of the box and use a smile lenticule for corneal perforations.
Thank you, Chintan. And I think we have so many very interesting talks which are yet to come. But this is something which I started using not a very long time ago. And it was mainly, I think, during the COVID times and post COVID that we actually started using a lot of smile lenticule because there was a shortage of good tissue. So, if you look at the use of biological tissue for managing corneal perforations, it's amniotic membrane or conjunctival flaps, or we have tenon patch grafts, and various types of scleral grafts and other corneal grafts, and we also have the tissue adhesives like the fibrin glue and the cyanoacrylate glue. And in times of shortage, we did end up using a lot of scleral tissue to seal these kind of perforations because they are like full thickness, and this was a peripheral perforation, so the graft did very well. With so many smile procedures being done, we looked at the lenticule which we obtained after smile surgery, because this is an excellent tissue. It's just a smooth stromal lenticule. It is readily available if you want to harvest it, and it is inert relatively, and you don't really have to go to too much of hassles to process it before you store it or you use it. So, most of the cases where smile lenticule has been used are cases where you could get away with using cyanoacrylate glue also. So, why should you use smile lenticule vis-a-vis cyanoacrylate glue? We know that the cyanoacrylate glue is synthetic, it is pro-inflammatory, it is what leads to a lot of discomfort in patients, causes inflammation, and it's just a temporary means till it sheds off. And most important, causes so much of vascularization that sometimes to rehabilitate these eyes optically becomes next to impossible. The smile tissue, on the other hand, is a biological tissue, and it has better tensile strength, provides a stable scaffold for the corneal repair. Classically, how many of us have very used to seeing this kind of a picture a few weeks after applying a cyanoacrylate glue? Look at how thickened the upper eyelid has become. It is inflamed, chronically inflamed eye with just a huge amount of vascularization coming in. Even if you do an optical graft after that, it won't stand a very big chance of survival. Now, this is the first case that I did, and this was an area of thinning, post-herpetic keratitis, and very important here is to create a nice bed with vertical edges, because you want to stabilize the smile lenticule there. And once you take the lenticule, you shape it according to the size that you want to seal. In this case, I thought I could get away with just a little bit of cyanoacrylate glue, but ultimately it kept leaking, so that I had to apply a huge amount of glue. And the patient otherwise did quite well and healed well. So we went on. I prefer using sutures, and that's what literature also advocates. So important thing, as I said, is to just have spend some time on making vertical edges. In this case, I have undermined the edges, and so that the suturing is much better. And IOCT is being used, and this often can guide us to how thick is a graft that we need in these cases, and how are we doing. So this patient also did quite well after surgery, healed very well, and went on to undergo an optical corneal transplant with good restoration of vision. So this case of infective keratitis, Dr. Radhika showed in an excellent way that fibrin glue that she used. I tried to use fibrin glue. It doesn't really work every time. It becomes very difficult, and I ended up actually using cyanoacrylate glue in this patient, but he did quite well and it healed. So what are the advantages of corneal stromal lenticule? It is safe, efficient, it is inexpensive, it's an acellular tissue and does not require eye bank setup, and it's a biological tissue, so it's less reaction. And what does the literature say? There are not many studies which are there, but they indicate that in majority of studies there was a maintenance of anterior chamber after the use of smile lenticule. No significant complications, no cases of rejection, or no recurrent cases of infection have been reported as yet. The limitations, well, there is a narrow range of diameter of the corneal lenticule. So, you get 6 or 6.5 millimeter lenticule, and therefore it is not suitable for very large perforations. Limited thickness of most lenticules. So, usually 100 to 140 microns, we usually would not go beyond that. So, it may require multiple overlapping of the smile lenticules to give us the adequate tectonic strength required. It requires careful handling of the tissue, and I just reviewed some of the literature. This is important for us to know what other people have done. So basically, one of the initial studies, they used, they did test all the donors of the smile lenticule for viral markers, as well as they have some other studies have noted that they should be free from any corneal and systemic disease or any other history of corneal surgery. So that's what has been noted in various studies. So they have stored, this particular study stored in BSS with the concoction of antibiotics and antifungals to store it at -80. Some people have used Optisol, like we have used Cornisol in our patients. Our people have used 0.9% normal saline, and many of these studies have actually used 10-0 nylon sutures, and I would myself advocate the use of 10-0 nylon sutures when it comes to using the smile lenticule. Most of these outcomes have been very encouraging and positive. Some more studies in a similar way they have noted, and there's only one study where they used fibrin glue, and that was, and these the inclusion criteria was microperforation or lamellar tear. So full thickness fibrin glue, normally it doesn't really give you the kind of strength to seal the perforation. So just a few tips on utilizing the smile lenticule. The donor smile lenticule from patients of myopia correction, at least 5 diopters, preferably 6 diopters or more. And the lenticule is stored in Cornisol. That's our protocol. And we can do cryopreservation at -80 degrees. So to conclude, there exists a significant future potential for smile lenticule to be used as biological tissue or and replacement for maintaining the ocular integrity, especially for small corneal perforations. Corneal thinning also, it does very well in that scenario, averting the need for a therapeutic keratoplasty and its associated complications. Thank you very much. I'll take any questions. Thank you.
Thank you very much, Dr. Amit, for nicely covering the topic and use of smile lenticule. It is a very useful technique, and it sort of adds to the armamentarium of tissues that can be used. Thank you so much.
Thank you.
I would request the audiovisual people to please put the timer.
I have a question. Can I ask?
Yes, of course.
Dr. Amit, I just wanted to check with you. Like usually when it's a beautiful technique, it's like, do not waste what you can save. So, but my only question is, routinely when we do refractive surgeries, we don't ask for a HIV test in the patients, but the eyes that we get and we transplant, we usually do that. So are you in your center asking for an HIV testing before using these smile lenticules, or?
This is entirely optional. And initially, our experiment with smile lenticles initially began with trying to store it properly. We experimented with various techniques and got down to Cornisol, which is all right to store it. But yes, ideally before doing it, you must screen it. But as a routine, it's very difficult to do in refractive surgery patients. But it's a surgical protocol. You can ask them. But sometimes people voluntarily do it. It's fine.
So I have one or two questions on that. One is that how do you use fresh one or a cryopreserved one?
So we are using preserved ones because our
Preserved.
I mean, we are preserving
Cornisol
just in Cornisol,
not
regularly,
cryopreserved
just like a regular
minus
graft. We are not storing at -80.
-80 you are not.
Yes, we can store in Dalbecos at -80.
Okay.
We have done that also.
Okay. Second question is that I have seen that they have grouped differently, like the SMILE group and AMG group. My question is, have you tried that it is with AMG? Because your thing is much thinner, 100 micron, 140 micron. Perforation is say 500 micron, though it is small, maybe shelving is there. But if you top up with AMG, because there are several studies. Only AMG can also correct the thing after a long time. There are very beautiful papers are there. So this is on top of it. If you give AMG, so it will be more strengthened. This is my suggestion. Actually, you can think and you can have, because you are doing it regularly. So in fact, the COVID has taught us many things. Then a lot of innovative thing. So even we are using like DISEC anterior cap. That is again more thickness, like 350.
Correct.
So DISEC anterior cap, DMEC, we can get the full thickness, lamellar, tectonic, perforation, whatever, up to 9.5 we could say, for temporary purpose. Then you do the final procedure. So a lot of innovation has done, nice presentation, but preserving it and again use it for future is another option if you have facility of -80.
Correct. We can do that. I mean, amniotic membrane. What I find is that patients where we've used the smile lenticles have healed very well on their own in an excellent way. Amniotic membrane will of course add to it. There are only a couple of studies where they have used smile lenticule with amniotic membrane. The results are no different from studies where they used smile lenticule alone. There was one study in what I presented where they compared amniotic membrane graft to seal versus smile lenticule. There were two groups. They didn't put amniotic membrane on top. They used two groups. So their results were almost similar actually, not too different. The smile lenticule group was only slightly better. In fact, that's the only study which reported that there were some cases of perforation. Flat AC following that. Otherwise, all the studies have reported a very good outcome.
So can we add glycerin preserved corneas also in this?
Yes. So in COVID era, we used everything actually. So whatever in our hand.
Purpose is not optical.
Purpose is not optical. So initially, anything in your hand spareable or you are throwing otherwise in the dustbin, so that is to be used.
So what we have realized is if you have a thick lenticule, don't throw it. Just
That
save
is
it.
thick lenticule
You never
versus
know
thick.
where it might save you.
Required, yes.
Keep it for your emergency ORs, keep it for perforating injuries which are stellate or they have tissue loss. You can use it in so many ways. It should be available 24
That
hours.
is
Actually.
also right, absolutely. Okay, third.